Hello, friends. So let's start. Okay. Uh, so obviously, as you know, today we will be discussing AIIMS May 2020 anesthesia questions. So let's start straight away with the first question. Massive blood transfusion will present with all of the following except. So let's start. So massive blood transfusion will present with all of the following except hyperkalemia, hypokalemia, hypercalcemia, and hypocalcemia. I think majority of you would have done it wrong. It looks to be easy question, but really very tricky and very difficult. So before discussing or before I tell you, you have to tell me the exact answer. Okay. So what should be the answer? You can write me. Yes. What should be the answer? I'm not seeing your answers. You can write me. Okay. What should be the answer? Namaste, Bhargav. Hello, hello, Saurabh. So, what should be the answer for this? Massive blood transfusion will be present with all of the following except hyperkalemia, hypokalemia, hypercalcemia, and hypocalcemia. Okay. Anushka says C means hypercalcemia. XYZ say hypocalcemia. Amit Singh says hypercalcemia. Anyone else? Yeah, C. C. Yes, very nice. That's good. I wasn't expecting that so many of you will attempt it right. Yes, it's hypercalcemia. Okay, very good. Correct. There will be hypocalcemia. So, not hypercalcemia, correct? There will be hypocalcemia. And why hypocalcemia? You very well know that citrate chelates calcium. And there will be big citrate load during massive transfusion. And definition of massive transfusion, you know that we are replacing whole blood volume in less than 24 hours, means around 5 liters of the blood you are giving in less than 24 hours. That is classical definition of massive blood transfusion. So that will be associated with hypocalcemia because that will cause enough citrate load, and this citrate will chelate the calcium, leading to significant hypocalcemia. Hyperkalemia, obviously this stored blood has uh, increased potassium, so there will be hyperkalemia. So can anyone tell me why there will be hypokalemia? Why there will be hypokalemia? Anyone? Anyone can tell me why there will be hypokalemia? Okay. Uh, Anyone? Why hypokalemia? I know many of you have attempted it hypokalemia, but there can occur hypokalemia in post-operative period. Okay, massive blood transfusion is associated with acidosis or alkalosis. Will there be alkalosis or acidosis? Yes, you can reply. I'm not saying reply. What happened? No. Massive blood transfusion is always associated with significant alkalosis. And why there will be alkalosis? Because this citrate produces bicarbonate. Citrate on metabolism produces bicarbonate. One citrate molecule can produce three molecules of bicarbonate. So there will be significant alkalosis. And alkalosis is always associated with hypokalemia. But this hypokalemia is not seen during transfusion. It will be seen in post-op. And it happens. At least two patients I have seen in post-op, they are developing significant hypokalemia after massive transfusion. Two times we have seen in ICU patients after massive transfusion we shifted and patient developed significant hypokalemia. So post-operative, patient can have hypokalemia. So immediately during transfusion you will find hyperkalemia, but post-op you will be finding hypokalemia. Yes, and hypocalcemia I told you is really significant because citrate chelates calcium. So the answer will be C, correct. Yes, very good. Yes, good. Good, Suraj. Okay, let's go to next question. Again related to transfusion. A 26-year male patient with the RT complicated with pelvic fracture has been resuscitated with blood transfusion. After a few hours, he became febrile, hypotensive. CPP was normal but oliguric and bleeding from nasogastric tube and IV sites. Most common diagnosis, although it's an easy question, I don't think there should be any confusion. But still, I'll wait for your answers. It should be a simple question because I don't think even choices there can be any confusion in this. But still, what should be the answer? Yes. Yes, what should be the answer? Okay, Amit. Amit has attempted fat embolism. Anyone else? Yes. Manjunath says transfusion reaction. Yes. Then few more answers and then we'll discuss. Yes, few more answers. Okay. So I don't think there should be any doubt in this that it is a blood transfusion reaction. Mismatch blood transfusion. See, mismatch blood transfusion usually present with fever, rigor, chills, And if the patient is conscious, then patient will have flank pain. That is also a quite common symptom we have seen. So fever, rigor, chills, flank pain, and then patient can develop significant hypotension, and then hypotension, and then there will be increased bleeding, either from surgical sites if it is done during surgery, or from other site like nasogastric tubes or IV cannulas, and the reason for that is DIC. So this is the typical presentation of mismatched transfusion, or you can say ABO incompatibility. So it's typically getting fitted. Patient is having fever, hypotension, and eventually these patients goes in renal failure. And why? You know that this blood transfusion reaction, it is confirmed by hemoglobinuria. So this hemoglobin in renal tubules can block renal tubules, leading to renal failure. So patient has gone to that stage. That means he has become oliguric. So this is typical, very typical of blood transfusion reaction, ABO incompatibility. Fat embolism, number one, will not be presenting. Yes. So fat embolism will not be presenting so early. Usually fat embolism present after 24 to 48 hours. And typical presentation of fat embolism, is patient has dyspnea, and there will be petechial hemorrhages over the chest. So fat embolism will have dyspnea. Patient will desaturate. Oxygen saturation will be low. So no way it is getting fitted, and definitely patient will not be febrile at all. So in fat embolism will not be febrile, and yes, hypotension can be there, and CVP normally in fat embolism will be little high because of the right ventricular strain, and usually it present after 24 to 48 hours. And it will not be presented with bleeding from NG tubes or IV sites. It will be mainly presented with petechial hemorrhages. Okay, so I don't think there should be any doubt in this. Somebody has written hemorrhagic shock also. No, hemorrhagic shock, why after few hours will present with fever, and in hemorrhagic shock obviously CVP will be low. In shock CVP will be low. So beyond any second thought, it is a transfusion reaction. Okay. Question number 3. It's again very easy question, more than easy in fact. In ECT, thiopentone and succinylcholine are used for reduce anterograde amnesia, anesthetic and muscle relaxant to induce epilepsy, as bronchodilators and decrease secretions. I think it's very easy, or the easiest question which can be asked. Yes. What should be the answer? What should be the answer? I think there is some delay in chat. Yes, Nikhil, correct. Some more answers, then we'll start discussion. Yes, I don't think there is doubt. Everybody has attempted it rightly. This is anesthetic and muscle relaxant. However, for ECT, that induction agent of choice is methoxytone, not thiopentone. But since methoxytone is not available, so we are using thiopentone. But thiopentone we have to use actually in low doses, because at usual doses, thiopentone is actually anti-epileptic. very strong anticonvulsant. So thiopentone in low doses we use, and actually ideal I told you is methoxytone, IV agent of choice for ECT because it is epileptogenic. But since it is not available, so we are using thiopentone in low doses, and succinylcholine obviously to avoid injury for muscle relaxation. But we have to see the convulsions, otherwise how will we know that convulsions has occurred? When you are giving ECT, you are inducing convulsion, so you have to know that whether convulsion has occurred or not. So if you give muscle relaxant, how will you see the convulsion? So what we do, we apply tourniquet. In one hand we apply tourniquet so that the succinylcholine will not be able to reach that hand, that limb. So in one hand we apply tourniquet, and then we see muscle contractions in that hand in which you have applied tourniquet. Okay. So thiopentone as anesthetic agent, and obviously succinylcholine as a muscle relaxant. Okay. Question number 4. If those who are the regular students, I told you that this question will be definitely asked. Chest trauma patient which is not the initial ventilator setting. FiO2 100%, tidal volume 10 to 15 ml per kg, PEEP 0 to 5 centimeter, inspiratory flow 60 to 100 liters. Okay, so this I'll wait for the answers and then only will start. Okay, Sanjay. Sanjay says B, correct.
अभी करो स्टार्ट एक बार.
Now is the stream working? Okay, guys. Now it's okay. Is it working? Okay. So it's working, I think. Okay, fine. Okay, so this question, 65-year-old male with abdominal pain for 6 hours, BP 96, 90-50, respirate 24, saturation 92% with 10 liters of oxygen. Abdominal X-ray shows extraluminal layer in abdomen. That means he has perforation. Which of the following must be done in shifting to OT? Intubate the patient. Initial IVSS of choice is central venous catheter. Confirm the diagnosis with CT. 2 to 3 liters of crystalloid infused. No problem, Arya. Just after this question, I'll repeat that ventilator question. Don't worry. I'll go back again, don't worry. So we'll discuss ventilator question this. So now just answer for this question number 5. I'll repeat ventilation question. I told you, don't worry. After this question, we'll repeat. So what the answer for this question number 5? Anyone else? Someone said C. Other questions? D, A. Anyone else? Some more answers. Hmm. Yes. See, why you want to intubate the patient? Saturation is 92% and respiratory rate is 24 breath per minute. For putting mechanical ventilation, if you remember, I told you criteria is that respiratory rate should be more than 35 breaths per minute. So putting a patient on ventilator, or you can say intubating the patient, respiratory should be more than 35 breaths per minute and PO2 should be less than 50. Less than 50, or you can say less than 60 in this case, if you are oxygen more than, if in spite of using oxygen more than 10 liters, and 60 usually corresponds with SpO2 less than 90% usually, or if you consider 50, it is usually corresponding with around 87 or 88%. So there is no need to intubate in current situation. And yes, patient is having hypotension. Why? Because in perforation, they significantly loses the fluid. So you have to just transfuse at least 2 to 3 liters of crystalloids, and crystalloid of choice will be ringer lactate before taking the patient to operation theater. You have to stabilize, give fluid. Otherwise, during anesthesia, as soon as you will give anesthesia, patient will immediately collapse, because all anesthetic drugs, they causes hypotension. All drugs they causes hypotension, so patient will immediately collapse. So we have to resuscitate, give at least 2 to 3 liters of the fluid, and then only we will take this patient for anesthesia. Okay. Diagnosis confirmation, no need, it is perforation already. Extraluminal layer clinical presentation is enough. And at this stage, if you shift the patient to CT scan, patient is on a borderline saturation and patient is in hypotension, so patient is not stable, in fact, to shift to CT scan, patient can collapse, and we have seen patient getting collapsed while unstable patient shifting to CT scan room. Okay, clear, fine. So we'll go back to the ventilation question. I think some people missed this. Where is the eraser gone? Okay, so I don't know why eraser is not coming. Anyway, so what I was telling you is, uh, for ventilation nowadays we have to go for What has gone wrong with my pen? I'll reconnect. Just a second. It's not working. Now it's working. Okay. So, what I was telling you is nowadays we have to go for lung protective strategy for ventilating a patient. And the two most important part of lung protective strategy is that tidal volume should be less than 4 to 6 ml per kg, not the normal tidal volume of around 10 to 12 ml per kg. And with that, I told you if you use low tidal volume, you can reduce mortality by around 9%. Forget about morbidity. Mortality can be reduced by around 10%. So we have to go as a rule of low tidal volume 4 to 6 ml per kg. Very important. Tidal volume has to be 4 to 6 ml per kg. And second part, very important part of lung protective strategy is that plateau pressure should be less than 30 centimeter. And why we are choosing plateau pressure? Because plateau pressure, denotes lung compliance. Lung compliance means it denotes alveolar pressure. And why we are using uh, less tidal volume? Basically, aim is to decrease the barotrauma, and barotrauma obviously will occur at the alveolar level. And since this plateau pressure represents alveolar pressure or lung compliance, so it should be less than 30 centimeter. And the best way to decrease this plateau pressure is using the low tidal volume. That is very important. And peak airway pressure, the peak pressure, it denotes the airway pressure, but more important is the plateau pressure. Okay, so we have discussed. Okay, this question: calories from TPN: 100 gram dextrose, 30 gram amino acids, and 40 gram lipids. Yes, waiting for the answers. Calories from TPN: 100 gram dextrose, 30 gram amino acids, and 40 gram lipids. Waiting for the reply. Then we'll discuss. Thank you, 2020. Okay, still waiting for the answer. Although it's little difficult question from undergraduate's point of view, but AIMS, yes, it is AIMS. Okay, somebody calculated 680, somebody 860. Okay, some more responses. Some more responses, then I'll start. So you just tickle your brain. Shweta says 680. D. B. Okay. I think it shouldn't be difficult because although in TPN there is a little difference, but even if you go by simple biochemistry, you will be able to answer this question. 1 gram of dextrose normally produces 4 calories, but in TPN it is 3.7 kilocalories. Normal it is 4, but in TPN 3.7, although this is controversial, some books you will find 3.5, some books you will find even 3.4, but the latest guideline is 3.7. So 3.7, 1 gram is 3.7. 1 gram of protein, you all know, is around 4 kilocalories, and lipids, 1 gram of fat, you all know, is 9, but TPN it is little high, 9.1 approximately. Okay, so we can calculate 100 gram into 3.7, so it will be 370. 430 grams, 30 into 4 will be 120, and 9.1 into 40, so 9.1 into 40, 364. So 4, 15, 854 is the exact calories with this combination. So nearest answer will be 860. 860. So if you go by normal, not means TPN, there is a little difference. I'll not go in that much details because protein here are amino acids. So amino acids, and then dextrose, dried dextrose is little different from the glucose, so it's little less. And lipid is normally 9, but in TPN it's little high. So even if you go by normal, so say by 4, 1 gram dextrose produces 4, so it will be 400, 120, and 9, 360. So still it comes out to be 880. So again the most nearest answer will be 860. So answer should be 860. Okay. This is more or less an anatomy question, not an actually anesthesia question. But since we see this every day during intubation, so I included this. And this all you know anatomy far better than me. Pyriform fossa is this. And significance of this is that normally tubes, very often it slips into pyriform fossa. You're not able to intubate, either it goes in esophagus or sometimes you struggle and your tube gets stuck in the pyriform fossa. So this area epiglottic fold can be damaged. So anyway, important from why I included this question is just to discuss the grade of laryngoscopy. And you know that no need to go in that much details, but uh, Kotak and Lehane is the classification for difficult laryngoscopy. So grade 1 you can see everything. So it is almost grade 1. All structures are seen. Means full vocal cords you can say. Vocal cords fully seen. Grade 2 only the posterior part. And grade 3 you will be only seeing epiglottis. You will not even see the vocal cords. And grade 4 even epiglottis is also not visible. No structures, no laryngeal structures visible. So this is almost grade 1, full laryngeal inlet you can say. So intubation will be easy in this patient. So B, pyriform fossa. I think these are the only anesthesia questions. Any doubt or any question which you could remember I couldn't find? Any other question or any query, any specific thing you want to ask? Yes. Any doubt? Later also, if any doubt, you can mail me, Dr. Yadav, Ajay at the rate of rediffmail.com or uh, anesthesia query group on Telegram and always on eGurkle. There is a query section. You can always post your queries in eGurkul. We try to respond as early as possible. So any platform you can use, my personal mail, my personal group, or you can also write on eGurkul. Okay. So anything else you want to know? I'm still waiting. If any query, any question. Amit Singh, mechanism of transcutaneous stimulation. It is gate control theory, Amit. And you must have read gate control theory in physiology. That sensory stimulation leads to blockage of pain gates in spinal cord. So that is the mechanism of action of transcutaneous stimulation. Okay, Amit. Gate control theory. Details of gate control theory you can read in much detail in your physiology. Any other thing? Thank you, Arsha. Thank you, Anushka. Thank you, Amit. Any other thing you want to ask or any other question which I missed? Okay, so should I wrap up the session? Okay, guys, thank you very much. Later also, if any doubt, I told you, you can always contact me through my mail